Hydrops fetalis is a serious condition where excess fluid builds up in at least two fetal compartments, such as under the skin or around organs. This occurs when the fetus can no longer maintain normal fluid balance. To keep the fetus clear, meaning balanced, calm, and free from excess fluid buildup, several key physiological factors work together to maintain normal fluid levels in fetal tissues and cavities. We can remember these important factors using the mnemonic CLEAR. C. Cardiac function. Healthy heart maintains normal hydrostatic pressure. L. Lymphatic drainage removes excess fluid from tissues. E. Endothelial integrity. Capillary walls stay intact, preventing leakage. A. Albumin maintains oncotic pressure in vessels. R. Red blood cell mass prevents anemia and high output failure. However, when this balance is disrupted by diseases, fluid begins to accumulate abnormally, leading to hydrops fetalis. These diseases could be cardiac defects such as atrioventricular canal or arrhythmias, volume overload and cardiac strain in case of twin-to-twin transfusion or tumors, lymphatic obstruction such as Turner syndrome, infection, such as cytomegalovirus and syphilis, liver dysfunction, fetal liver fails to produce adequate albumin, anemia. Causes include Rh isoimmunization and parvovirus B19. These underlying conditions are associated with increased venous pressure, decreased oncotic pressure, and capillary leakage. Together, these changes cause tissue edema and the accumulation of fluid in fetal body cavities. When fluid is present in two or more compartments, the condition is diagnosed as hydrops fetalis. Hydrops fetalis refers to the excessive accumulation of serous fluid in the fetus. OPS. Diagnosis of hydrops fetalis is made when there is fluid accumulation in two or more fetal compartments, the seen on ultrasound. O over distended abdomen of ascites. P pleural effusion. Pericardial effusion. S skin edema greater than 5 m. The letter S looks like a 5, reminding us that skin thickness greater than 5 mm is significant. In some cases of HF, placentomegaly and polyhydramnios may also be evident but are not part of the diagnostic criteria. Placentomegaly. Placental thickness is greater than or equal to 4 cm in the second trimester or is greater than or equal to 6 cm in the third trimester. Hydrops is divided into two types. Immune hydrops, 10% of cases, happens when the mother's immune system attacks the baby's red blood cells, called red cell alloimmunization. Non-immune hydrops, 90% of cases, caused by other problems and not related to the mother's immune system or red blood cell antibodies. Etiology of immune hydrops. Immune hydrops result from the transplacental passage of maternal antibodies. These antibodies destroy fetal red blood cells, leading to fetal anemia. The anemia stimulates erythroid hyperplasia in the bone marrow. As a compensatory response, extramedullary hematopoiesis occurs in the spleen and liver. Hepatic hematopoiesis interferes with normal protein synthesis in the liver, resulting in decreased plasma oncotic pressure. The fetal anemia also causes tissue hypoxia. This combination contributes to fetal heart failure, which raises central venous pressure. The increased pressure and hypoxia result in greater capillary permeability. As a result, fluid begins to collect in fetal compartments such as the thorax, abdominal cavity, and subcutaneous tissue. In immune hydrops, the anemia is typically very severe, with fetal hemoglobin levels often dropping below 5 grams per deciliter. The incidence of immune hydrops has significantly declined in recent years. This improvement is due to several key interventions: the routine use of anti-D immune globulin to prevent Rh sensitization, the use of middle cerebral artery Doppler studies to detect severe fetal anemia early, and timely fetal blood transfusions when indicated. Etiology of non-immune hydrops. Mnemonic NIHF. N. No known cause. Idiopathic. Although a specific cause can be identified in at least 60% of cases during pregnancy and over 80% after birth, about 20% of Hydrops fetalis cases remain idiopathic. Normal middle cerebral artery peak systolic velocity with no abnormality findings may suggest idiopathic Hydrops. Numerical chromosome abnormalities, aneuploidy, is the most common cause of non-immune Hydrops fetalis before 24 weeks of gestation, accounts for approximately 20%. The most frequent aneuploidy was Turner syndrome, followed by trisomy 21, 18. When Hydrops is detected in the first trimester, the risk of aneuploidy is around 50%, and most cases are associated with cystic hygromas. Neurologic anomalies. Structural malformations of the central nervous system that adversely affect fetal development. Absent corpus callosum, encephalocele, holoprosencephaly. Eye. Infection. Infections cause around 14% of non-immune Hydrops fetalis cases. The most common infection is parvovirus B19. Other infections include cytomegalovirus, toxoplasmosis, syphilis, Coxsackie virus, and rubella virus. Inherited metabolic and genetic disorders include Gaucher disease, Niemann-Pick disease, mucopolysaccharidosis (MPS), and neonatal hemochromatosis. I. Intracavitary lesions. Obstructive or space-occupying lesions within the fetal chest or abdominal cavity that interfere with normal fluid dynamics include chest masses, cystic adenomatoid malformation, diaphragmatic hernia, pulmonary sequestration, intrathoracic mass. Abdominal, pelvic lesions. Bowel obstructions with perforation, such as meconium peritonitis, volvulus prune belly syndrome, congenital nephrosis, posterior urethral valve. H. Heart disease. Cardiovascular disease is the most common cause of non-immune Hydrops fetalis. Accounts for about 15% of cases. This includes fetal arrhythmias, premature closure of the foramen oval or ductus arteriosus, hypoplastic left or right heart syndrome, Ebstein's anomaly of the tricuspid valve, cardiomyopathy, cardiac tumors, and other structural heart defects. Hemolytic anemias such as alpha thalassemia, RBC enzyme deficiencies, feto-maternal hemorrhage, twin-twin transfusion in the donor fetus. Hemodynamic disturbances include vascular accidents, intracranial hemorrhage, thrombosis of renal veins, IVC, twin-twin transfusion recipient fetus. Vascular malformations, chorioangioma, placenta, umbilical vessels, liver hemangioma, cerebral AV malformation, sacrooccygeal teratoma, Klippel-Trenaunay syndrome, hypoplasia of the skeleton. Includes conditions like asphyxiating thoracic dystrophy and osteogenesis imperfecta or chondrodysplasia F. Fluid drainage disorders like lymphatic malformations include pulmonary lymphangiectasis, cystic hygroma, multiple pterygium syndrome, Noonan syndrome. These conditions block or disrupt fetal lymph flow, leading to fluid buildup and Hydrops. A quick summary of all the causes of non-immune Hydrops fetalis. Complications and prognosis in Hydrops fetalis. Maternal mirror syndrome, Ballantyne syndrome. Maternal mirror syndrome is a rare and serious complication of non-immune Hydrops fetalis. It occurs because of fetal Hydrops and leads to sudden onset and rapid maternal deterioration. The condition is called mirror syndrome because the mother's symptoms reflect the fetus's condition. It's also known as triple edema, as edema affects three areas. 1. The fetus develops Hydrops fluid in body cavities. 2. The placenta becomes swollen, placental edema. 3. The mother develops preeclampsia-like symptoms. Generalized swelling, high blood pressure, protein in urine, perinatal morbidity and mortality. Prognosis of Hydrops fetalis. Hydrops fetalis carries a high perinatal mortality of 50 to 90%, depending on the cause, timing of diagnosis, and response to treatment. Cases with better prognosis. No structural or chromosomal abnormalities. Late onset hydrops. Good response to fetal therapy. Survival improves significantly in treatable causes, especially with fetal therapy. Parvovirus B19 infection. Chylothorax, lymphatic effusion. Fetal tachyarrhythmias. Each accounts for approximately 10% of cases. With intrauterine therapy, survival is possible in up to 2/3 of affected fetuses. The prognosis of non-immune Hydrops fetalis is generally poor, especially in untreatable causes. Cases with poor prognosis. Genetic syndromes, major structural defects, or cardiac anomalies. Early onset Hydrops. Involvement of multiple fluid compartments. No access to fetal interventions. Diagnostic evaluation, investigations. Hydrops fetalis is all about abnormal fluid accumulation, so it's only fitting to use the word fluid as a mnemonic to organize the key investigations. F. Fetal imaging. Purpose. Diagnose hydrops, detect associated anomalies, and suggest possible causes. Ultrasound. Look for fluid in 2 or more compartments. Ascites, pleural or pericardial effusion, skin edema thicker than 5 mm. Note associated signs: cystic hygroma, polyhydramnios, placentamegaly. Watch for isolated findings. Pericardial effusion. Think parvovirus B19. Pleural effusion. Consider chylothorax. Edema of involving the upper torso or the dorsum of the hands and feet may be found in Turner or Noonan syndrome or may represent congenital lymphedema syndrome. Skin edema in the fetal head and neck, often in the first sign of fetal hydrops in early pregnancy, 11-15 week. Generalized skin edema, diffuse thickening of the skin greater than 5 mm all over the body, is a late sign of fetal hydrops. Middle cerebral artery Doppler. Increased peak systolic velocity is consistent with fetal anemia. Fetal echocardiography M-mode, look for structural heart problems or arrhythmia. Ultrasound signs that suggest in utero infection, in addition to hydrops, include calcifications in the brain, liver, or pericardium, microcephaly, ventriculomegaly, hepatosplenomegaly, and intrauterine growth restriction. L. Laboratory maternal blood. Purpose. Exclude immune-mediated or hemorrhagic causes. Indirect Coombs test. Rules out Rh alloimmunization. If negative, proceed with full non-immune Hydrops fetalis evaluation. Kleihauer-Betke test. Detects fetamaternal hemorrhage if fetal anemia is suspected. U. Uterine access invasive tests. Amniocentesis and chordocentesis. Purpose. Obtain fetal fluid or blood for genetic, hematologic, and metabolic testing. Amniocentesis amniotic fluid. Karyotype for major chromosomal abnormalities. Chromosomal microarray for small deletions or duplications. Test for alpha thalassemia if fetal anemia is suspected. Screen for inborn errors of metabolism, which are genetic disorders causing abnormal metabolite levels due to enzyme defects. Metabolite assay example. Increased phenylalanine in phenylketonuria. Enzyme assay example. Decreased enzyme activity in Gaucher disease. Chordocentesis fetal blood. Confirm and quantify fetal anemia, hemoglobin, reticulocyte count. Metabolic screening enzyme assays for lysosomal storage diseases like Gaucher, Niemann-Pick, or MPS hemoglobinopathy panels to look for abnormal types of hemoglobin like in alpha thalassemia. I. Infections. Purpose. Identify infections known to cause non-immune Hydrops fetalis. Maternal blood is used for initial serologic screening. If maternal tests indicate recent or active infection, confirmation is done by PCR on amniotic fluid. Parvovirus B19. For IgM antibodies. Cytomegalovirus CMV. MVIGM and igavidity. Toxoplasmosis. Toxoplasma IgM and Ig. Syphilis. Screen maternal blood with RPR or VDRL, confirm with treponema test if positive. Treat and monitor according to standard guidelines. DNA and genetic testing. Fetal DNA from amniotic fluid amniocentesis or cord blood cordocentesis. Purpose: detect subtle or syndromic genetic causes not found by karyotype. Chromosomal microarray finds microdeletions and microduplications. Targeted gene panels or exome sequencing. Use if ultrasound findings or family history suggest a specific syndrome, for example, Noonan syndrome or certain skeletal dysplasias. Management. Expectant management. For the fetus. 1. Fetal monitoring. Ultrasound monitoring weekly or biweekly to track fluid levels and cardiac status. MCA Doppler (PSV) to screen for fetal anemia. Fetal echocardiography for detailed cardiac assessment. Daily fetal surveillance in the third trimester using non-stress test and biophysical profile. If Hydrops resolves, repeat ultrasound in 2 weeks to assess fetal growth. 2. Growth and maturity. Antenatal corticosteroids if preterm delivery is likely. Minimize interventions unless fetal compromise is evident. Plan delivery between 34 to 38 weeks if stable. For the mother. Maternal monitoring. Watch for mirror syndrome, hypertension, edema, proteinuria. Manage polyhydramnios conservatively, amnio reduction only if maternal discomfort is severe. Conservative management includes maternal antivirals, digoxin, corticosteroids, antithyroid drugs and beta blockers. Can be considered if all of the following conditions are met. Fetal conditions. Fetus is alive. No fetal distress. No malformations incompatible with life. Fetus is immature, preterm. Maternal conditions. Patient is not in active labor. No preeclampsia. Termination of pregnancy. Indicated in any of the following conditions. Fetal conditions. Fetal death. Fetal distress or non-reassuring test results. Presence of malformations incompatible with life. Fetus is mature, gestational age is greater than or equal to 37 weeks, or lung maturity confirmed. Maternal conditions. Patient is in active labor. Development of preeclampsia. Fetal therapy and intervention. According to the latest recommendations published in the Obstetrician and Gynecologist, TUG, 2023. Now, let's discuss it in details. Treatment according to the mnemonic mentioned before: NIFH. I. Infection. Cytomegalovirus, herpes simplex, toxoplasma gondii, treponema pallidum. Maternal antibiotics or antivirals. Inherited metabolic and genetic disorders. In utero enzyme replacement therapy, stem cell therapy, gene therapy. Intracavitary lesions. Solid congenital cystic adenomatoid malformation. Survival rates. 0% if Hydrops is already present. Up to approximately 90% if no Hydrops at diagnosis. When Hydrops develops in a solid lesion. Open fetal surgery. Improves survival to approximately 50% but significant maternal fetal risks. Hemorrhage, infection, preterm labor. If surgery is not elected or feasible. Serial monitoring, ultrasound plus Dopplers. Maternal steroids, in some centers, to promote lesion regression. Urinary tract causes. Megacystis with normal renal function, suggested by normal urinary electrolytes. Therapy. Vesico-amniotic shunt or fetal cystoscopy. Tumors. Open fetal surgery has been used in a small number of surgically correctable tumors, especially solid pulmonary and sacrococcygeal tumors, which can cause non-immune Hydrops fetalis due to obstruction, high-output cardiac failure, or vascular shunting. Open fetal surgery, rare, only for small, resectable tumors. Direct, in utero, resection of the mass. Improves hydrops and survival but high maternal fetal risk. Less invasive alternatives when feasible, as alternative to open surgery. Percutaneous alcohol injection, sclerose feeding vessels. Radiofrequency ablation of tumor tissue. Thermocoagulation, ultrasound-guided. Ultrasound-guided alcohol installation into tumor. Aim: decrease tumor vascularity, size. Relieve high output failure. Resolve hydrops. H. Heart causes and hematologic causes. Fetal anemia. Detected by serial middle cerebral artery peak systolic velocity (PSV) is greater than or equal to 1.5 mom suggests moderate to severe anemia. Therapy. Intrauterine blood transfusion. Top off red cells until fetal hemoglobin hematocrit is safe. Repeat intrauterine blood transfusions may be needed depending on cause. Fetal arrhythmia. Supraventricular tachycardia, atrial fibrillation, atrial flutter. First line, no or mild hydrops. Maternal digoxin, if inadequate response, add sotalol or flecainide. If hydrops are persistent arrhythmia despite first line agents. Direct fetal therapy, intra-amniotic or intrafetal injection of antiarrhythmics, such as digoxin, flecainide. If fetal compromise, heart failure plus hydrops. Right pointing arrow, consider early delivery, if viable, or term immediate intervention. 2. Thyrotoxicosis related fetal tachycardia, Graves' disease. Maternal therapy. Propylthiouracil in first trimester or methimazole in second, third trimester. Beta blockers for symptomatic relief, if required. B. Structural cardiac lesions. 1. Critical aortic stenosis with evolving hypoplastic left heart syndrome. Fetal aortic valvuloplasty, balloon dilatation in utero. 2. Pulmonary atresia with intact ventricular septum. Fetal pulmonary valvuloplasty. Hematological cause. Fetamaternal hemorrhage or parvovirus causing hemolytic anemia. Even when asymptomatic in the mother, severe hypoplastic anemia leading to fetal hydrops. Timing, risk. Risk of fetal loss is highest in the first half of pregnancy, especially between 16 to 32 weeks gestation. Favorable signs for spontaneous recovery, no immediate intervention. No thrombocytopenia. Absence of acidemia. Elevated reticulocyte count. If there is evidence of fetal anemia on blood tests or elevated MCA-PSV. Intrauterine blood transfusion. Guided by middle cerebral artery peak systolic velocity MCA-PSV Doppler to confirm anemia severity. Note: intrauterine blood transfusion carries a slightly increased risk of fetal loss, but most cases have successful outcomes. Monochorionic twin pathology. Twin-twin transfusion syndrome. Treated with one or more of the following. Laser ablation of placental vessels. Amniodrainage. Persistent severe twin-twin transfusion syndrome or complications. Umbilical cord occlusion. Early delivery or pregnancy termination in severe cases. Twin anemia polysemia sequence. Mild TAPS. Close surveillance weekly MCA-PSV monitoring. Moderate to severe TAPS. Fetoscopic laser ablation, selective termination, or fetal exchange. Transfusion, trapped twin reversed arterial perfusion sequence. Targeted intrafetal laser ablation of a cardiac twin vessels. Radiofrequency ablation of a cardiac twin's umbilical cord. F. Fluid drainage disorders. Includes fetal hydrothorax, chylothorax, with or without bronchopulmonary sequestration, or congenital pulmonary airway malformation. Therapies. Needle thoracentesis, serial drainage of fluid, thoracoamniotic shunt, continuous drainage into the amniotic cavity, maternal corticosteroids, used if the lesion is microcystic congenital pulmonary airway malformation to promote regression.